Great, thank you. So good morning, everyone, and thank you for attending. For those of you I have not met, my name is Roger Conway. I'm the Senior Clinical Systems Analyst for the ambulatory solutions that we are implementing at Lumio. And on today's agenda, we're going to go through the integration of charges into ambulatory workflows, which will be done by Bruce Harlan, as well as Jeff Strain will take us through a clinical intake documentation demo, and then we will just discuss next steps for our next meeting on currently scheduled for Tuesday, September 10th at 11 a.m. So, Bruce, I guess you're free to take it away.
Yep. And I don't know if Julie was going to try to join either, but so my piece on this will be pretty quick. With charge, oh, sorry, wanted to make sure I wasn't muted. Just realized I should check that out first. So with the charge team, what we're basically doing is making sure that we have any kind of change control or any kind of changing modifications that occur on y'all's end gets passed on to our finance team. So whoever that is at the respective each of the respective facilities. So I think we'll have to get with Julie with the list for who those all are, but we want to make sure that y'all are aware because the new system changes, especially how it integrates and impacts with the finance system. Everything y'all do is clinically driving that charge to be generated. Um, and when I say charge, I think of it in more of the US sense. I know y'all don't really consider charging as the same thing like I would. So there's a little bit of a terminology difference there. But either way, what we want to make sure of is so as you are going forward, and this is ambulatory, if you are adding a new workflow or a new let's say procedure or service line that y'all are performing and it's something y'all hadn't done before, that's where we'd want to make sure that once y'all have identified that and y'all have worked out how that's going to look on your team and whoever that might impact or who needs to do whatever, that then that information gets passed on to the finance team so that they can then go through and embed any kind of revenue necessary statistics or metrics into that charge as well. So this would be if there's any new orders or if you aren't using these new a certain order anymore. It's not just if it's new things, it's if you've changed things, if things are being removed. So like new orders being removed, you've adjusted the workflow so you might not be using an order. It might be a form or something like that. Um, Anything like that, or if y'all got new vendors that are already utilizing, it's just always helpful to pass it on because then finance can then make that determination if that is relevant to them or not, or if it's going to impact them. Um, but that is one of the biggest pieces for it. I think the big takeaway on the on this working group kind of for the ambulatory team is what does that strategy look like? So, or what does that communication channels look like when y'all do get something new? Or if there's any kind of adjustments, how are y'all going to communicate that downstream to the finance team? Is this making sense so far? Or are there questions? I take it as it is making sense then.
I see
So,
John had his hand raised. Sorry about that.
Yeah,
John, did you have a question?
just a real quick question, Bruce. So basically, in your experience, it's just best if we make any workflow changes to notify finance and let them determine what's impactful on our on charging.
yeah, I think that is one. I mean, there's certain things that may not be as relevant, but in the most case, yeah, if it is something where you're using a new order or new process, right, it's communicating that down to them. So in instances like if you know there's something that it's a new procedure or a new service line and you know that's something y'all have charged before, then you definitely want to get that over to them and any other kind of information they might need. But if it is something you're not sure about, I think that's where it's helpful to then probably reach out to that team like, hey, we're doing this. What do you need information on it? What kind of information do you need? Because there's some things, especially in y'all's world, where it may not be as relevant as a factor for y'all. Does that make sense?
Yeah, it does. Yeah. Thanks, Bruce.
Yeah,
And Bruce, if you wouldn't mind, I just want to
absolutely.
mention something as well. And speaking of this, it's not the expectation that you, as the clinical working folks that are taking care of the patients, that would be reaching out to these different parties, such as finance and whatnot. There's going to be
Mhm.
a change control process in place as well. So when there needs to be updates to the system or changes to the system or anything new added to the system, there's going to be a process of vetting that out. One, to see what, if in fact that it's technically possible, what can be done based off of, our analysis and what those limitations, if any, would be, and what the priority would be. So if we've got, let's say, 10 different changes that just come up at the same time, there would obviously need to be a prioritization as to which of those are the most important. Let's say, it's a patient safety issue. So if someone had something, a request waiting for 2 months, and it was, determined, okay, that's going to be done, and this is just example. So don't quote me per se on this, but if it was determined that you had, or your organization or your department had requested a change, and that there was sort of an estimated date where, let's say, we were going to implement that in a month, your change was number 3 on the prioritization list. That list is not necessarily set in stone, right? Because as each day or hour goes forward, there are things that can happen, as we all know, in healthcare in general. So there could be a potential, if there's something of like a patient safety risk or something like that, that obviously would move forward first. But the idea is not necessarily for you folks on the phone to be reaching out to the the charge folks. Like, we would vet that out during our process, and then we would perform the analysis to see if in fact there's some kind of impact in regards to the change that you're requesting that would potentially affect finance. Now, if you know this offhand, of course, we want you to identify that to us and to the group. But, we're not expecting you as individuals to be reaching out to the finance department specifically. This is not necessarily a responsibility for you. I mean, we're us on the IT team. We all work with each other, and we all work with you, and we will do our best to do what we need to do to have this change happen effectively and safely. So I just wanted to, make sure that it was clear that it's not necessarily on you per se to be reaching out to all of these individual teams. It would vary depending upon specifically what has been identified, but we are all here to support you and to support the system as well as maintaining it.
Yeah, thank you. I'm glad you added that in there, Roger. Yeah, this is something where there will be that process, this change control, where there's a bit more of a formal process to it of getting it notified. You wouldn't have to worry about that actual end user on the floor who's actually treating a patient having to be the one to reach out. It would go through the change control process.
Any other questions on that topic? Okay, great. Bruce, did you have anything else to add, or?
No, I think big piece is just starting to get that conversation. I'm sure that's what y'all are going to kind of be doing in your own working group, but making sure that as y'all are fleshing out your process to keep the finance side in mind, right? So that's really what we wanted to get on here and kind of preach about, I guess, a little bit, is just keeping them in mind and making sure that you include them in that process for anything that might come about. But that's all I've got. So
Great.
if that's it, I will let y'all get back to it. And please, if y'all have any questions, feel free to reach out to me or anyone else who's a part of the finance team or whoever that might be. But I do appreciate it.
Thank you, Bruce. We appreciate it. Thanks for your time.
Mhm.
Jeff, is it okay if we turn it over to you?
Absolutely.
Great,
Just
thanks.
gonna get my screen shared. Morning, everybody. Let me know when you guys can see.
I
You're
can
good,
see your
Jeff.
screen.
Perfect. Okay, guys, I'm Jeff Strain. Good to talk to you all again. We're going to be going over clinic or ambulatory office intake documentation today. So I'm just starting here, signed in as a ambulatory RN or LPN, so a nurse that would function within an outpatient clinic. So when they first log into the Lumio system, they are going to fall onto this landing page here that includes the ambulatory organizer. And they do have these quick links to open up a patient's chart or their encounter or visit for the day. So I'm going to just open up my test patient here. First thing that they're going to land on is the outpatient workflow page. And the easiest way to jump directly into our clinic intake documentation is a little drop-down arrow within this vital signs component. And this contains a number of what we refer to as forms or power forms, one of those being the ambulatory comprehensive intake. So with that ambulatory comprehensive intake form, once it is selected, it is going to prompt onto the screen. And then we land on the summary page here. So if you ever hear something referred to as a form or a power form, we're kind of talking about the overall documentation or ability to document against this form here. And then within this form, we have different sections. So these are the sections of the ambulatory comprehensive intake form. And these are meant to be fairly comprehensive, but also fairly general to support the needs from a number of different programs or specialties. So you'll note there's not things that specifically call out individual specialties per se. It is meant to be a broad encompassing form that everyone can leverage to the best of their abilities. So that said, I'm going to go through a few of these sections. You guys, please feel free to ask questions about the process, and I will try to explain it along the way. But if you do have questions, feel free to stop me. So starting with chief complaint is very similar to our reason for visit field. A reason for visit is actually captured by scheduling. So chief complaint could be something a tad more specific. So if I want to enter that chief complaint, I can put that in, and this is going to help populate that outpatient workflow page, patient communication preference, if that is phone calls, and if this is an accident-related visit, we can type in any information about that. Beyond that, we do have vital signs to capture. And you notice that I'm not having to click through each of these boxes. As long as everything is lined up horizontally, we can tab through those boxes and get to the next item. Getting into the weight field here, put that in, get a good height, blood pressure site, heart rate. After that, so there's our vitals and measurements. We do have our pain assessment. Does the patient have any pain? Is that what they're here for? You can just directly select no. Selecting yes is going to make these additional fields available. So our numeric pain scale, pain location, we can document the particular site of pain that the patient is communicating, as well as any comments that we want to here. So this is just a free text pain comments. After that, we do have just a PHQ-2 depression screening, and then depending on the answers to those questions, what we would call that is conditional. So if I answer yes to either of those two questions, we get the full PHQ-9 detailed response or detailed depression screening here that I would be able to go through. If that was an error, I can always hit that back button, choose no here. because the patient is not feeling that way, but I just did want to show. So normally I can't get directly to that PHQ-9 without first answering yes to one of these first two questions, which would then allow me to go through and get my PHQ-9 documentation. I should probably note that if there are any sections or any details on this form that you would not use in your particular clinic or in your particular program or specialty, they don't have to be filled in. So most of this documentation is optional, and we're going to document what we need to for that patient's clinic intake. Next section is community pharmacy information. So we want to input the patient's pharmacy of record or the pharmacy that they like to use. So we have the pharmacy's name, address, phone number, and fax number here. These are all free text boxes so that you guys can get that typed in. We're not making any limitations to the format or the responses there. Drug coverage, this includes drug coverage information. So if it's none, Ontario Drug Benefit, Ontario Drug Benefits, home and community care, private insurance, any commons, and their drug card. The next few sections here, I actually get into more Lumio specific functionality rather than just free text responses. So first off, we have the patient's allergies. If these are not already captured, we can capture them. So we can add allergies directly in by choosing that add button. And if I want to choose something like penicillin, because the patient is allergic, well, not hit that category to work.
Hi, Jeff. If they've been to a site before us and this has already been captured, will it come forward to us as well?
It absolutely will. So if
Perfect.
they have been to any of the 6 sites within the region that are also using the Lumio system, that would already be there.
Okay.
And we would have that information. You'll notice here, if I'm documenting an allergy that has an interaction with the patient's medication that's currently prescribed, the system will warn me of that as well. So we're doing a retroactive check of the patient's allergies. We also have not only drug allergies here, but I believe we have food allergies in the system. So if the patient is actually allergic to shellfish, we do not check against that just because this is a non-multum related allergy, but then we would put this into food. We can't enter other items about that allergy. So what's the severity if the patient knows where that information came from? Did it come from a patient? Did it come from a family member, guardian, etc.? Once we have that, all we have to do is hit OK. That is going to show on the patient's allergy list. We also have the option of if there's no known medication allergies, that is just a quick add here. Patient doesn't have any medication allergies that they are aware of. We can choose that button, select OK. Now the patient's on NKMA. Excellent question about whether this would come forward. So when or if this information has already been documented, I open up the patient's form or I open up the record and I see their allergies. I ask them, hey, anything changed with your allergies? I can just mark these as reviewed, and that will actually stamp that as, yes, I looked at these, I reviewed them on this date and time.
Okay, great. Thanks.
Very welcome. Beyond that, we have our best possible medication history. This will show you all of the things that have been prescribed to the patient or the patient currently has orders for within the Lumio system. So if they have a number of prescriptions, those would be here. But if I needed to add a home medication that the patient is on, whether that be something significant, something not as significant, I would add that here. So I can see the patient has an outpatient allergy testing order. But if I wanted to add something here, to say that the patient is on Lexapro. Oh, what is the actual generic name? There, we'll go something simpler. Patient is taking low dose aspirin. So that's going to add to my list. The system does give me the ability to say what their actual dose is if they know, what they're taking, is it daily, as much information as we can capture about that medication as we can, and then we can hit document history, and that will actually add this to the patient's medication list. It's going to function very, very similar to orders, but it is a documented medication by history, so home medication list, if you will. That also does update our reconciliation status. So depending on how closely you guys monitor the medication reconciliation, that would show that my medication history has been addressed for this visit or for this appointment. That will bring me to the next section here. This goes to our problems. Problems display as differentiated between the problem list, which is the bottom half of this screen, and the diagnosis component. In general, diagnoses are reserved for physicians and mid-level providers where anyone can add to the problem list. Problem list, and actually, I'm going to take a quick step back. Tara, your question about allergies and whether or not if the patient had been to another site, if this would be populated, that is also true for the medication history. And it's also going to hold true for the problems list as well. So I just want to keep that in context that it's not always going to show up blank and that we are going to be sharing this patient-specific information across all 6 sites leveraging Lumio.
Okay, yeah, perfect.
Yeah, so if anyone had that question, yes, this is absolutely shared. And that includes the problem list. So if the patient has a chronic problem that maybe that we want to be aware of, but we're not necessarily addressing today, say the patient does have asthma, we want to make sure that we include that. We can include additional details. We don't have to. So a patient has asthma, started at a certain age, but this was confirmed and it was told to me by the patient. We can hit OK. That is going to get the patient's asthma listed there. If it's something like hypertension, that could be added as well. And then the good thing about these is they can later be converted to a diagnosis that the physicians are using to address at that visit. But as a nurse or LPN, we don't necessarily have to worry about adding diagnoses because we do not have that capability. Okay. Moving on to our procedures and surgeries. This is more of a procedure and surgical history. Same thing. If this is something that you guys capture as part of your intake documentation, you're more than welcome to. It will also populate from the other sites that are using Lumio. So if the patient had an appendectomy or something that we want to note, or other relevant surgeries or procedures, we can search for that, add them in, and we can get that as part of their record. So if I want to look for appendectomy, and grab that. If we know the date, even better. If not, it is not required information. So we're just saying that they've had this procedure when it was last reviewed, but we would leave that procedure date blank. I think we can get close to dates. Not. Okay, scratch that. But there is our procedure history. Social history, a little bit different. It is a little bit more structured. So if social history is something that you capture, especially tobacco, alcohol, substance use, that can be captured here in the social history. I would hit add, and then we actually have this broken up into different subsections, if you will, and we can look through each of those. So for my patient, have you ever used any form of tobacco in the last 6 months? If they're a never smoker, we can say no. We can also go through and document their alcohol usage, if that is something that you capture. So we hit OK, that is going to populate. And then kind of the last item using these controls that I call them is family history. If we want to add family history because that's something relevant to the program that you guys are in or that the program documents, you'll see that we have the relationships across the top, father, mother, brother, sister, grandfather maternal, grandmother maternal, and then we can scroll over for more of those. And once we have that, we would just be documenting a plus or minus in the column if we're trying to say that. So father had heart disease, mother, something like diabetes. We can add those in, simple plus or minus, and then that would add mother and father, family history of disease. Okay, I'm going to take a quick pause after showing those controls. Any questions or anything that you guys want to see or know a little bit more about? Okay, I will continue on. If you do have questions, stop me. We have an interpreter services section here, relevant for anyone that's speaking a different language. Psychosocial spiritual, this section here, if this is something that you document as part of your program, I do want to talk a little bit further about the infectious disease screen. This is denoted as required. Any information that's required on a form is going to appear in yellow boxes. So that's going to give me my visual indicator that I do have to document this information. When the question is answered, it will go back to white. And then, so this is again conditional. So is that patient or support person available to provide answers to the infection control screening? If I say yes, this is going to open up a number of other fields in my infectious disease screen. If I say no, it's going to keep them closed or dithered, and that is going to satisfy the requirement for my infectious disease screening. Just out of curiosity, is this something that most of your outpatient clinics or ambulatory programs are documenting today?
We're documenting on the registration point. We ask those
Okay.
questions on registration, but yes, they're documenting them.
Okay, so that's like a registration or check-in activity before the patient ever gets to a nurse?
Yeah.
Awesome. Okay. Getting past that infectious disease screen, we do have additional measurements. So if there are things that are specific to your program or specialty that you are documenting beyond just those standard height and weight measurements, we can come here to capture anything additional. Same with more vital signs. If we need to do orthostatic vital signs or a deeper dive into the patient's respiratory function, that is here on this form. You guys take a little bit longer look at that one. Subjective, this is going to go through almost like a head to toe assessment. We have pain, general symptoms, activity tolerance, cardiopulmonary, or I should say more of a systems assessment, cardiopulmonary symptoms, gastro, we have GU, we have skin, standard hours of sleep. So this really gets into more of a systems assessment and allowing you to document what is truly going on with this patient. We also have activities of daily living, so this goes into more of those things. I don't know how frequently this is going to get used in every single clinic, but it is here. And again, the form's intention is to be comprehensive and broad so that it can be used everywhere. Our GI and GU assessment, so anything specific to GI and GU, bowel assessment as well on this section. Education needs, this allows us to document barriers to learning, patient and family learning style preferences. So is it demonstration, is it printed materials, verbal explanation? We can also free text any additional information that we want to capture about the patient's education. We have our Columbia Suicide Severity Rating Scale frequent screener. This is in here if it needs to be used. We also have a fall risk scale, and I'm totally understanding that not each of these tools or pieces of documentation are going to be used with each visit. Sexuality assessment is here. OB-GYN history. The whole top half of this is actually related to pregnancy and documenting an active pregnancy or capturing an active pregnancy, which you'll notice, given that my test patient is a male, that does not appear. And then menstrual history as well in that. And then concluding with advanced directive. Does the patient have an active advanced directive? Yes, no. Additional information about their code status and other wishes. And then our patient and caregiver goals. So this can be more tailored to the specialty or program that the patient is being seen by. The actual goals are text goal example, can be written in free text. Relevant disciplines for that goal can be documented. So is it our allied providers? Is it a nurse? Is it our specialty program? And if that is not present, we can document other. John, I see you have a question. Go ahead, sir.
Yeah, I got a question, Jeff, about the advanced directives. So how does that work with the goals of care? Like I know we're going away from like code status, going to goals of care. So if someone has an advanced directive, do they have to have the aligned with their goals of care, or are they two separate things?
I think from the perspective of this intake form, they are two separate things. It's kind of unfortunate that they are mutually exclusive, but I think we would want to have that documented in both. Does that help answer your question? I don't think they actually speak to each other between this section of the intake form and that goals of care item.
Sure. I just wonder, maybe that's a conversation that physician will have to have with that patient if they have an advanced directive and it doesn't necessarily, line up with what their goals of care are now, I guess.
Yeah, I think you're absolutely correct on that.
Okay. Thanks, Jeff.
No worries. Good question. Jumping back to that patient goals, relevant disciplines for that goal. So if it's specific to our nurse, status of that goal, is it initial, progressing, goal met, revised, not met, discontinue, the date that it was met, if so, and any comments. Again, this is going to be free text comments about that particular patient or caregiver goal. Okay, so that goes through the whole form. One other thing that I do want to point out here is our performed on date is going to say when this information was captured or when it was documented. So if we're ever backdating or, hey, I actually captured this history 30 minutes ago, an hour ago, I know that 30 minutes to an hour may not make a difference, but if it's something that was from yesterday, we may want to change that date because all these results or all the information that I put into this form is going to get tagged to this date and time. But once I have everything filled in that I want to, and again, you don't have to go top to bottom. You don't have to tell nursing staff or whoever's capturing these histories or intake documentation that every single one of these sections needs to be touched. I was just going through it to show you all today. We would hit our green check mark to sign the results. The system is going to prompt me that I am about to sign just to make sure that I want to do so. And then I will sign that. We have pinned. I think I just need to submit that part. Okay. So what's going to happen there is we now have that document or that clinic intake form completed. And if I refresh my outpatient view, I'm going to notice that most of or a good portion of that information has now come over to my workflow in page. So I have the vital signs that I just captured. I also have allergies that we've input, home medications that we've input. And then if we get into the actual, find the histories here, get into the histories, patient's chronic problem of asthma is now there, procedure history, appendectomy, my family history, mother and father that was documented, my social history, my alcohol and tobacco use, etc., is all there. So all that information coming directly into my workflow page, which is now going to be visible and present to the provider that is seeing this patient. Tara, I see you got your hand up. Go ahead.
Yeah, after you sign that form, because say for instance they were here for a transfusion, after you sign that form, are they able to go back in and add the vitals? You know how they check them sometimes every 15 minutes, every 30. How would they add that if it's already been signed?
So that's really just the initial capture. There's a couple different ways they can. If you want to add just a set of vital signs, if I jump back up to my vitals component on my workflow page, we do have an outpatient clinic, just a vitals height and weight form that's going to allow you to document those just as your vitals without going through that whole comprehensive intake. So
Oh,
they
perfect.
could use this, and this does have those orthostatic and other vital signs that we see on that comprehensive form, just to give them a quicker way to do so. And then for some of the, I will say like medical day units or um, infusion clinics, if you will, they will have access to interactive view where they can go and document those vitals there if it's something that they're doing frequently. Now, if it's just a quick recheck of vitals after something, I would probably send you to this form just to grab that additional set of vitals and sign off on them.
Yeah, no, I was specifically thinking of the transfusion clinics and things like that, which is done in our ambulatory clinics here. So
Okay.
yeah, perfect. Thank you.
Yeah, so this would be probably mechanism number one where I can just go back to that vitals component, go specifically to that vitals height weight form just to give me the condensed look. Additionally, if I want to go to interactive view, we can go to vital signs here, which is going to allow me to, in more of a flow sheet style, document this patient's vitals, tabbing through this section and entering those, especially if it's something that I'm doing like you said, every 15, 30 minutes or an hour, this is probably the quicker way to do so.
Oh, okay. Thanks.
Great question, though. Um, but you do bring up a good point. What happens to that form? What if, oh, I signed it off? I need to change something, or I didn't capture something that I want to make sure gets included. The tab on our dark side or our blue menu here is the form browser. This is going to let me see all the forms that have been charted for this patient. And if I need to, I can see the instance that was documented at 11:15 today. I can go right click and modify. That's going to re-prompt that form, all the same information I had in it. And if I need to change something, whether it be about the vitals, whether it be about the summary, anything that I had documented on this form that needs to be modified because it was not captured correctly, we can do that from here. And then we would just sign again. If I don't want to modify, choose to cancel, and we're good. But this is going to give you, this form browser going to give you a overall view of all the forms documented for that patient on a particular date. Okay, so we've noted how this information is flowing into the actual workflow in page, the different components here, my problem list, all the histories, etc. I do want to show one more thing. We have in the more section here. Okay, I'm going to flip over to the provider sign in just for a second. So now you'll notice, and we can see this by looking across the top, very, very top of the screen here. This is a ambulatory physician sign in. They have a very similar view with a couple of additional items here, but their landing page going to be very similar where they can see those vital signs, home medication, even that chief complaint that was entered, who entered it, on what date and time is present, so they're aware of how new that information is. But what I want to bring up to show you guys how this actually functions. So if I have an outpatient office visit note and the provider goes to start their documentation, really what this helps out is it's going to grab all of that information that we've captured as part of intake. So my vital signs and measurements, and then really almost everything on this right side of that provider note is populated from information that we can capture within the comprehensive intake. So our problem list information, procedures, medications, allergies, social history, family history, all of that information is going to make our notes much more relevant, our visit notes much more up to date. So as much as that as we can capture is going to be even better for our providers. All right, let me jump back to that nurse sign on here. And I will pause one last time for questions that you guys may have about this intake documentation, whether it's, hey, where is this? What is missing? What's not missing? Let me have you guys' questions. All right. Well, thank you guys for allowing me to present. Roger, I guess I'm going to turn this back over to you, sir.
Great, thank you. So I guess just to wrap up today's meeting, is there something special or in particular that anyone would like to see as far as workflow system demos for our next meeting that's currently scheduled for Tuesday, September 10th at 11 a.m.? Anything specific workflow system-wise for ambulatory?
Hey, it's Sonia from Providence Care. I apologize. My camera isn't working today. I also manage, as much as the ambulatory clinics, the interventional psychiatry clinic, which does ECT and ketamine, TMS. And so we have check-in stuff for patients that are coming for a procedure. And it's through this whole project, it's kind of fallen on different places, whether it's surgical, whether it's mental health, whether it's ambulatory. Didn't know if there was anything in this group that pertains to those, because they are coming to a clinic and we do have a check-in, like a pre-procedure checklist kind of thing.
Yeah, Sonia, if you wouldn't mind just maybe responding to Roger and I on this meeting invite and kind of walking through some of those documentation items or workflows, we can
Sure.
try to get you some of those answers. I think that would probably
Okay.
be the best way. I don't have anything off the top of my head that we would necessarily demonstrate, but I do agree with you. A lot of that's going to fall into the ambulatory space, whether it's, the initial scheduling of the visit, the patient's, intake and check-in process, etc. So we'd probably like to gather some more details from you on that.
For sure. I'll send you an email.
Thank you so much.
Thank you.
And I guess just out of curiosity, I know like during the kickoff and whatnot, we sort of gave directions and where to go as far as the Lumio library to look at specifics for ambulatory. Has everyone gotten a chance to go into that library and just poke around and have a look at the specifics as far as workflow and any kinds of information? Because that resource is also available for you to review, and perhaps also that would generate some questions. So I just want to be sure that we're utilizing the best of everyone's time and to be able to, particularly transfer the knowledge of these changes. So it would be great if we had something specific that you'd like to look at system-wise or workflow-wise for our next meeting. So if nobody has anything now, perhaps, think about it and get back to us sort of sooner than later so we can have something prepared and to present for you all at that next meeting. And maybe, talk to some of your colleagues and see when you're, sort of if, just speaking in general about what's coming to see if there's anything specific that you'd like to look at and for us to review. So you have our emails on that invite. So if you can't think of anything now, please just perhaps a few days before that next meeting, if you can just sort of ping us and let us know specifically so we can sort of, work on presenting what would be best for your needs. Does anyone have any other questions? You're good. Samantha, anything?
Nope, I have nothing.
Okay, well, great. Thank you all for your time, and I hope this was informational and helpful to you, and look forward to speaking to you all at the next meeting. I appreciate it. Have a great day.
Thanks, everybody.